All right. Hello, everyone, and welcome. So my name is Basharia Keys. I am with the National Association of Community Health Centers, Director of Policy and Regulatory Affairs. Really excited to be here at Howard today. Fun fact, I am a double HBCU grad. Um, so I went to Spelman College in Atlanta for undergrad, and I went to Howard Law. So really excited to be here today at Howard. Welcome you guys to this session, and also the first health equity conference held by CMS, which is really exciting to be here. So this is the Inclusive Healthcare, Reimagining Provider Networks, Addressing Disparities, and Empowering the FQHC Workforce by Advancing Equity in Underserved Communities. So we have great speakers today and great presentations. I'm going to give just a quick overview, and then I'll turn it over to our presenters who will give you a full introduction. The first presentation is a West Side Story, Reimagining the Provider Network and Healthcare Workforce aimed at reducing social drivers of health. We have Art Jones from Wellness West, as well as Lillian Davis from Wellness West as well. The second presentation is Addressing Disparities and Empowering FQHC Workforce. We have Lucy Flores, as well as Angie Grover. And Lucy is from Partners in Health, and Angie is from Medtopia. Okay, great. And then lastly, but not least, we have Improving Equity in the Workforce by serving the underserved. Kate Parrish from United Health, as well as Amanda Pierce Kelly from Association of Clinicians for the Underserved. So thank you guys, and give our panelists a round of applause. And we'll start first with West Side Story.
Thank you. It's a pleasure to be here. My name is Art Jones. I'm the Chief Medical Officer for Medical Home Network and the Clinical Advisor for this project. And I'm joined by Lillian Davis, who is the Senior Account Manager for this program. So we were fortunate to be able to talk to you a little bit about Wellness West. Wellness West is one of 15 projects that are now sponsored and funded by the Illinois Medicaid Agency. The agency was concerned about health disparities among its population, so it commissioned the University of Illinois to do a study to look at how it could reduce disparities, identified several communities within the state that had a high incidence of health disparities, and one of them was the West Side of Chicago. So that as a result of that study, they created a plan, a health transformation plan, and a bill was signed passed by the legislature, signed by the governor, which is funding now 15 projects. In the first year, it's the 3-year projects, but the first year they committed over $90 million to support that. So put really some significant funding into that. Our particular project is focused on the West Side of Chicago, and particularly 10 zip code areas. There are roughly 200,000 individuals that are either medically uninsured or Medicaid insured in those 10 zip code areas. And when the U of I did their study, they saw, not surprisingly, a significant disparity in terms of a lot of the chronic conditions, severe mental illness, substance use disorder, mild to moderate depression, diabetes, hypertension, and also adverse childhood experience. So certainly that was where they wanted us to focus our projects on. But we really brought together a group of stakeholders to say what we were going to do differently. But not only was it really looking at the medical conditions, but also looking at the social drivers of health and the structural issues that were driving those disparities. So fortunately, Medical Home Network, which is, I'm also the chief, as I said, the chief medical officer for, had done individual health risk assessments for over 40,000 of our patients who lived in this particular area. We have an 85% completion rate for health risk assessments for social drivers of health. We actually published that data and showed that those drivers were actually predictive of not just those that were already going to be expensive, but the rising risk population. So if we could, in fact, address those social drivers of health, that we thought that would actually give us a good chance to improve not only the population health, but drive down costs. And that really was one of the main initiatives for the department. Medical Home Network is an integrated delivery system of 13 FQHCs, 3 health systems. We have 180,000 Medicaid beneficiaries. We are under a global risk contract, and we're completely delegated for care management. So care management is really done down at the practice level. So basically, we wanted to take our experience and say, could we actually improve outcomes? That area is served by predominantly 6 FQHCs, but there are other entities that are involved as well. And when we looked at the UDS data for those 6 FQHCs, really typical of what we see across the country is that, roughly a third of our patients that are diabetic had a hemoglobin A1C of more than 9 or didn't even get their hemoglobin A1C tested. Just so you know, obviously that's a really low bar. None of us should be happy with a hemoglobin A1C above 8. And for many of us, we're shooting to get it less than 7. So 9 is really pretty bad. So it's a low bar. Likewise, for hypertension, we're seeing that about a third of our patients had their blood pressure above 140/90. So we brought together really a multi-stakeholder group. So 12 FQHCs, again, 6 of which are predominantly on the west side, but 6 of others who have patients in the area, brought together 7 health systems, including the predominant children's hospital in the city of Chicago, the Cook County, which is the public health system, an academic center, and 4 safety net hospitals, but also brought together 4 community mental health centers and 15 community-based organizations that were dealing with these social issues. The concept for this was really based off of MHN's model, which we had already been doing for several years, which was to hire and train individuals from the community as care coordinators or community health workers, and not have them from an external perspective, not even have them embedded in the practices, but actually be employed by those entities. So they are part of the care teams. They are part of the staff at the community-based organizations. So the money flows down to those organizations who hire and train. So we developed a training program for that. We have we now have 142 staff that have been hired through this project, most of whom are community people that have been trained in the project. So although there are some licensed individuals, most of this is done by non-licensed individuals. So the community health workers are in the medical homes, or they are at the community-based organizations, or they are employed by the hospitals in the ED, or for the behavioral health providers, we're really looking for behavioral health trained staff that would do community-based care management. And the basis for the model is, again, as I said, is to have those community health workers, care coordinators be integral parts of the care team, and really be the interface between that patient building, doing the health risk screening and connecting those patients to the community-based organizations, but also really interacting with the primary care teams, the behavioral health providers, so that as a social driver health issue is identified or a chronic condition is identified where they would be benefited by getting support from a community health worker, that provider can open the door, introduce them to that, and do a warm handoff to that patient. So I will turn it over to Lillian to talk a little bit about our project.
Thanks there, Dr. Jones, and nice to be here with everyone today. And so to kind of go a little in depth into our model of care. So what we think is unique about our model of care is that, traditionally, organizations work in silos, medical, homes, FQHCs, and community-based organizations. But what we've been able to do is have an integrated delivery system across our hospital systems, our community health centers, our community mental health centers, and our community-based organizations, all working together, in which we have our CHWs embedded doing the work. There at those organizations, they complete what we called our health risk assessments, and they screen our individuals and refer them for social determinants of health. So this allows us to identify people at those various levels, right? Whether it's at the PCP level, at the behavioral health provider level, or at the ED and community level. Staff at our medical homes conduct disease management supports with their patients. So they do supports around hypertension, diabetes, depression, and adverse childhood experiences. Our behavioral healthcare managers are embedded in our community mental health centers, and they're able to work with their patients who may be struggling with mental health issues and some substance use disorder. And to kind of round out our model of care, all of our staff and workforce have access to our specialty care module, eConsult, in which they're able to refer patients for endocrinology and adult and pediatric psychology. And so we all know, we've been talking about this, and while we're here, that social determinants of health has a huge influence on community outcomes and individual outcomes, right? And so with our health risk assessment, we assess those different domains. So whether it's access to care, transportation, social support, housing, which is huge social determinants of health, or in our community and around the nation. Safety, food insecurity, financial strength, health status, and mental health and substance use. And so within our first year of operating, we have so far been able to do about 9,561 health risk assessments. And of those health risk assessments, about 77% of those screen positive for at least one social determinant of health. And so as you see, some of those that kind of like are glaring, that are really big for our population includes food insecurity, housing. People are worried about housing, and even individuals not having internet within their home. So some of our program outcomes that we're focused on and we're developed in regards to like some key performance indicators is around our social determinants, right? So, you know, how can we reduce social determinants within our population? And how can we re-administer our screening tool to see if we had any reduction in those social determinants of health as a result of our staff working with our patients. And the same goes for depression, hypertension, and diabetes. So how can we measure and have a clinically significant reduction in depression symptoms for our depression patients? For hypertension, how can we work with, have our staff working with our patients around uncontrolled hypertension to get them to a level of a more targeted blood pressure? Same for diabetes. You know, we look to see at least 20% of those that present to our program as uncontrolled to have a reduction in a hemoglobin A1C by the time they're finished with our program. Severe mental illness and substance use disorder. You know, how can we make sure that our behavioral health patients that have admissions, that they have that 7-day follow-up with a behavioral health care provider, and those who may be admitted for alcohol and other drug dependencies, how can we make sure they're connected to treatment within 14 days of that admission? And something that we also are looking to track as a KPI is our health equity impact. And so what we're doing is measuring some of our and stratifying some of our measures by race and ethnicity to see if we can identify any trends and address them in real time. And we're also looking at our BEP spend. And so what that is how are we working with organizations that are minority-owned or women-owned organizations to help us address these health inequities? And so how does our staff be digitally connected? How are they doing all this work? So we have a great web-based system named MHN Connect, in which staff are able to communicate, collaborate, and coordinate on patient care. So this this system allows staff to have kind of like a 360 view, patient view of their patient. So whether they're in the medical home or a community-based organization, they're all able to collaborate on the care of that same patient. And so this slide, we really are proud to say that we're trying to really build and create a culturally competent public health workforce. And for those who may not be familiar with the west side of Chicago, it's a predominantly community of color. And so far, what we've been able to do is hire up about 85% of our workforce that reflects the community that we're serving. And so a breakdown of that includes about 43% of those individuals identify as Black or African American, and about 46% of them identify as Hispanic or Latinx. And so we've been able to create a robust training curriculum for our community health workers, which include partners, which include our training partners, such as the American Medical Association, Habilitated System Incorporated, and Sinai Urban Health Institute. Again, we are working to really hire individuals with lived experiences and hire those individuals within the communities that we're serving. And so another thing that we've been really focused on and trying to do is really address the social determinants of health that our workforce experience, right? You know, they're working with individuals to meet their SDOH needs, but unfortunately, many times they have their own SDOH needs met as well. And so we've been able to develop a support fund for our workforce and also develop a consumer patient stipend program in which enrollees that are part of Wellness West are able to get training for free, and they receive a stipend to become a community health worker. And then at the end of that, they're able to at least interview with one of our partners for a community health worker position. And so we've learned a lot through the last year and a half. And so some of the things that I think that we wanted to kind of really share as some best practices is that, you know, we wanted to continue to develop some social interventions and be innovative on like how we address those SDOHs. We saw it was very important to curate different spaces for our workforce so they could collaborate, share their experiences, right? And share those best practices across their organizations. We saw also what's very important for this model to work is that our community health workers are integrated within their care teams and that we educate providers and organizations on the role and capacity of those community health workers. We also saw it's very important to offer multiple opportunities for educating and training staff on our shared use technology. And then also meeting patients where they are, right? Outside of the traditional medical settings to ensure that, you know, we build that trust to make sure that patients and clients are engaged with their medical providers. And lastly, we wanted to be able to establish targeted medical home and CBO relationships. You know, those medical homes or FQACs that are close proximity to some of the CBOs to have that connection. So it'll be more of a seamless collaboration and coordination of that patient care. And with that, that is our contact.
Well, before we let you guys go, do we have any questions from the audience for our presenters? Oh, yeah.
Also based in Chicago. And did you talk about how you funded this program?
So there's a question from the audience about funding. I had the same question.
Yeah, so this is funded for the first 3 years under a grant from the state of Illinois. So that they put in, as I said, 90 plus million the first year for 15 projects. We received that grant and it's a 3-year grant. The intent of this is that we will improve the model and that then this will be supported by integrated delivery systems by the managed care companies going forward. So part of this is really a proof of concept.
And then okay, maybe my question goes less. We have one more question in the back.
In regards to our curriculum, there's like multiple training partners we use. So for SUHI, Sinai Urban Health Institute, we use them in which they provide like a core skills training for community health workers. And so it's like about a week or so long training in which they learn core skills around community health work. So whether it's that health outreach, health literacy, motivational interviewing, things of that nature. And for the American Medical Association, they provide more so support around disease management for those disease processes, hypertension and diabetes. In regards to the certification in Illinois for community health workers, I want to say there's like a bill that may have been presented, but I'm not exactly sure if it was passed, but we are like kind of working to see if we could work with our elected officials to see if we could get some concrete like community health worker certification programs available.
Yeah, I would just add that Illinois did pass a bill that will eventually make community health worker services a billable service within Medicaid. Right now, that hasn't started yet. So part of the discussion is around whether certification. Medical Home Network developed a 6-month training program for community health workers early on and continues to do that program for our care coordinators. Basically, it's 6 months, but it's them coming in half a day, a couple of days a week. I mean, a couple of times a month because they also have to work and earn But right now, there is no official certification, as Elaine said, in Illinois.
Right, I'm sorry, we have to move to the next presentation, so we'll do the last questions at the end, but thank you so much for our presenters right now. And next, we have addressing disparities and empowering the FQHC workforce with data. It's black, but it should be coming up. There you go.
Good morning still, I think, everybody. We're so happy to be here and have other Chicago representation. My name is Lucia Flores. I am the Director for Partners in Health Chicago, but really here to speak about my experience with Metopio and Esperanza Health Centers, an FQHC on the southwest side of the city.
And good morning. My name is Angie Grover. My pronouns are she, her, and I am the COO and co-founder of Metopio, and we're the data sharing platform that drives all of the information we're going to share today. And I liked what Lillian and Dr. Jones said. We're going to take it to public health and FQHC partnerships. So I'm going to give you a little bit of a introduction. Let's see. Am I pushing the right button? Oh, green. Sorry. It doesn't matter if it's green, red, I never push the right button. We're really proud to work with the city of Chicago. Metopio's software is, our company provides software that shares data regardless of your data science experience. And so we worked with the city of Chicago to develop the Chicago Health Atlas in its current iteration. And the idea was that we wanted to have equitable data sharing because so often people with lived experience don't have access to the data and people with the data don't have the lived experience. And so we're really trying to drive equity through that data sharing. And so all of our partners came together and we developed the Health Atlas. It's a free resource. And the Department of Public Health and their great team of epidemiologists continue to keep it updated and use it for their work in Healthy Chicago 2020. Or I guess it's 2025, excuse me. So one of the interesting things that came out of COVID, obviously, but work that was driven by the Department of Public Health through their 2025 plan was to identify health equity zones. And I wrote this down so I wouldn't get it wrong. There are hyper-local strategies to confront social and environmental factors that contribute to racial and health inequality to close the life expectancy gap. And the life expectancy gap, as in many places where there's a lot of segregation in populations, is very large. And Lucy will talk a little bit about that. So they spent a lot of time focusing on this and engaging partners through data. And so Lucy and I are going to do a bit of an interview because she's the expert on the panel. And, you know, if you could tell us a little bit about your role in the health equity zone process and what you were able to learn when you started working with the city in that respect.
Sure, thank you. So I mentioned at the time that we were working or collaborating in this, I was the Director of Community Engagement at Esperanza Health Centers. And Esperanza is an FQHC located on the southwest side of the city of Chicago, serving a predominantly Black and Latino patient population, primarily Latino Mexican. And Esperanza represented two community lead areas, meaning that we were representing both the west side and the southwest side of Chicago. And Art and Lillian are here speaking about their work focused on the west side of the city. And that's not by accident. There exists something like a 16-year life expectancy gap between Black and Latino communities, and primarily Black and primarily Black men are the most impacted by that life expectancy gap in their white or non-POC counterparts. So a lot of the work that the Healthy Chicago Equity Zone work was focused on doing, or is still focused on doing, is working toward minimizing or reducing or eradicating that life expectancy gap for communities of color. And as I mentioned, Esperanza was the lead for two of the community areas. And in that process, we were tasked with developing a community needs assessment. Now, everybody here is probably very familiar with community needs assessments or CHNAs because most healthcare spaces are tasked with by HRSA and other funders to develop these profiles of our communities that we provide care in. And so we in the HCEZ work, we're specifically working with community-based partners to develop those needs assessments, not from a healthcare perspective, but just from a community needs assessment in terms of what do communities need to be healthy? What do communities need to be agents of their own change, right? And so a lot of the work that we did was focused on, yes, some health indicators that were found in the Chicago Health Atlas, but through participation with the Data Academy that was developed by a colleague at CDPH, the Chicago Department of Public Health, Margarita Reina. I couldn't cite this work without bringing her into this space because she really was the person who developed this Data Academy that introduced many of the HCZ partners to explore data, not from an epidemiological lens, but really from a community partner lens. And that is the lens and frame that I see through, not as a health expert. I'm not a medical provider. I'm not an epidemiologist, but I am someone who has lived on the southwest side of the city. I raised my family there. And have been in the health and healthcare space most of my professional life. And so I think that that's the lens that I contribute and brought to the Healthy Chicago Equity Zone work with Esperanza.
And Lucy, you talked about, we think about the social determinants of health. Somebody said today, that's the short version, but it's social, economic, and cultural determinants of health. And I think that's so very important. And some of the things that we curate for the Chicago Health Atlas touch on that. Where do you work? Do you have a job? Are you graduating from high school? What does safety look like in your community? Because they are the drivers. And so when we look at folks like MHN and doing work, getting to those core things, you're delivering health, but you're also trying to connect to some of these other variables. So do you want to touch on some of the things that you uncovered in your work?
Sure. So some of the work some of the health indicators that we looked at that I mentioned were not centered on diabetes or hypertension, which we would find what Dr. Jones was referring to, right, is high incidence of disease, the presence of disease. But some of the indicators that I mentioned were non-clinical, non-medical, non-healthcare focused, but impact health and health outcomes and larger life outcomes. And one of those was pre-K enrollment in the West Lawn community, which Esperanza has a clinic in. And really through the commitment of our medical director, Pete's medical director and school-based health center, he was really focused on wrapping ourselves around our patients and the greater needs beyond incidence of diabetes and obesity that lead to poorer health outcomes, right? We know that pre-K and academic achievement, if you are academically successful, that leads to other life outcome and is a predictor of future success, right? And by default or vice versa, if there is a limited number of children who are enrolled in pre-K in our communities, then that says that our children will experience less or decreased academic performance, will be less successful and have greater disease and experience negative life outcomes as a result of early childhood education and exposure to some of those really important services that happen in 0 to 5, 0 to 4.
Yeah, and I think what's most amazing is really how you guys dug into that topic, not being healthcare delivery, but very adjacent to it, and took that and took action. And I think what we all do is, and as I started the presentation, you might have the data, you might have the lived experience, but how do you combine the data with the community experience to actually put it into action and move some of these numbers? So I just love the stuff that you developed. Could you tell us a little bit about how Esperanza really embraced these indicators and put them into action?
Yes. First of all, I think it was Dr. Jones who at some point said data must be framed with a purpose. And we explored data as a result of what What is next? So what? So what that there are 8% of children in West Lawn that are enrolled in pre-K. If we don't contextualize that, and part of that included giving reference points, right? So 8% compared to what? In West Lawn, that's 8% of children enrolled in pre-K. The city of Chicago has a 56 enrollment rate. And in Lincoln Park, which is a north side, more affluent community, that's I think that the pre-K enrollment, if we looked at the health atlas right now, it indicates something like 78%. Now, 78% of children enrolled in Lincoln Park, in an affluent community with lots of access to resources. And I think that that's the action, right? That is what we bring to contextualize data, to frame it for our community partners. All of us don't need that framing. Our community partners and stakeholders who are embedded in communities that I represent here should be given these data points, contextualized, and then communicated to our parents, to our children, to our community-based organizations centering their work in education. I think that we translate, that is our responsibility in creating better health outcomes and actions that lead to improved health outcomes for our communities. So Esperanza embraced this wholeheartedly. I think that my agenda was community-centered, and they allowed me to run with it because their agenda extended or had an agenda that was beyond a medical care and healthcare delivery agenda. We understood that in order to improve health outcomes in our communities, COVID had demonstrated that we needed to network, we needed to build relationships and establish trust in our communities in order to create and help promote better life outcomes. People don't want to be served or saved. People want to be included. People want to be represented in panels like this. And I'm happy to see a really mixed audience here that is not primarily white, because that is one of those really big issues that people representing the work and the communities that we are talking about that are impacted by the issues that we are here speaking about are not often included on panels and in conversations like this one.
Amen. I couldn't agree more. And, you know, playing a role of providing the resources to have people like Lucy lead these efforts is what really is rewarding to us, because there are resources and they need to be redeployed. And I think data is one of them, and having this impact is really, really critical. And so I want to be respectful of time. And I think, you know, Lucy and I really just have the absolute pleasure and honor of working with Lucy, and she has inspired me, and she's also educated me. I mean, just as she shared with you, the ways that I can play a role in helping move these objectives forward. So what would you say is one takeaway for our audience today?
Connecting the data that you all have and translating that, working with community partners to translate that data, and then thinking together about what is that community partner's agenda and how can you all in the healthcare space be allies in advancing those agendas. It's not only about a healthcare agenda. The slides that Dr. Jones and Lillian showed us indicate that 20% of health outcomes are impacted by actual health or clinical care. 20%, that means that the other 80% is impacted by non-clinical or medical care. So what is our responsibility? To be active and participate in those. We need to create resources, translate data like in the posters that we saw. That's not the be all end all, but that's a start. And I think that that was a great start that Esperanza launched in collaboration with Metopio and the Healthy Chicago Equity Zone work. So thank you.
And my last takeaway for you is to broaden your sense of data. It's hard, but bring in that social determinants data. We find when we help clients put their medical outcome data alongside this social determinant data, it is really evident where you need to focus, and that brings resources to your community. It helps give the lived experience the data they need to be in these conversations and really advance health equity work. So we are really excited to be here, and thank you so much for your time.
And don't leave just yet. Okay, so we have time for 2 questions for our panelists. Do we have any questions from the audience? Amanda. So the question is, what's next?
Yes, I think that it's continuing to explore data. What are the data sources? What is missing in the data? And what is populating the data that Metopio is collecting, that CDPH is collecting? I think what's next is continuing to take this beyond one FQHC and really thinking collaboratively with other community partners. I'm now at Partners in Health, and I think that we continue to think about and consider strategy in terms of advancing health equity. Somebody earlier in the earlier session said health equity is a buzzword essentially, and people were working on health equity before there was even that buzzword. And I agree. I think that, speaking specifically about Chicago is the home for a lot of amazing work around life expectancy. And David Ansel speaks about the death gap, right? And the late Dr. Steve Whitman developed the Sinai Urban Health Institute that Lillian spoke about. So I think that there's amazing work being done. Obviously, my bias is Chicago because that's my home. But I think that what's next is to consider what is next, right? Like, let's point the finger at ourselves, at our organizations. Where do we have power and decision-making authority to advance an agenda? And that agenda should be, how can I help you advance your agenda in LASA Chicago, who is a violence prevention organization? Brighton Park Neighborhood Council, what is your agenda and how can we help improve community safety or academic achievement in our underperforming schools, right? So I think that that's what's next.
And I would only say, please support what the CDC and everyone else is trying to do in terms of data modernization, because I think Lucy pointed out something very important. A lot of people are afraid to share data because there's not perfect data, and we need to accept the data for what we have, use it, recognizing the caveats, truth telling with lived experience, and move it forward so we have better data. All the advances that OMB is doing with the SOGI data in terms of defining and collecting and the impact of these inequities on our LGBTQ plus communities. This is something that you have to be willing to do bravely and make it better, because if we don't take those steps forward, we won't have the information we need to command the resources and to put them in the places that we need to invest in.
And data is not only numbers and statistics. Data is listening to community members speak their truth.
Love that. We have one question. Is there, sorry, just have to repeat it for the folks online. So is there an example of a partner that you've used and also how they have leveraged the data?
I think really it was for Esperanza Health Centers using the information regarding low enrollment in pre-K. What some of the actions that resulted of that was using a community health worker like Labor Force, the public health ambassadors, who are now located in a couple of the lobbies at 2 of the sites, who are using iPads to connect families to, hey, this is the CPS enrollment portal. This is how you navigate it. This is the website for Start Early Chicago, an early childhood education resource, and logging in on the iPad and having a patient fill the informational form, which asks, I think, like 4 questions in addition to name and email address or best way to contact. So I think that those are really concrete actions that we had to think about, like, what do we have access to as a community health center to activate resources for our families in the waiting room? That also extends to now thinking about, hey, can we get a library card for your child to foster a love of reading, right? We have a Reach Out and Read program. And I say we because in my heart, I love Esperanza Health Centers and just recently left. It doesn't mean I don't love my partners in health community and folks there.
just one real other quick example. We, Saints Mary and Elizabeth is a hospital on the west side of Chicago, and they had a lot of people coming into their ED for asthma. And so, there's a lot of things to screen for, but we used the data to look at what could be driving that. And we found that building violations were highly correlated. So they found a community partner. They asked about housing, condition of housing, smoking. They had a pilot where they would then send someone out, say, are you willing to let someone come to your home? They did an assessment. They actually did the rehab for like mold, black mold, rodents in the HVAC. They provided renter support so these people didn't get kicked out after they were improved. Not one of their patients came back to the ED for asthma. That's connecting a health outcome with where you live, right? Where you live. So I think, digging in, taking that what is happening in your life and making it actionable is really important.
Well, thank you. Let's give it up for our panelists. I'll take a second. And then lastly, we have improving health equity in the workforce by serving the underserved. And they'll be. It's on. Yeah, they'll turn it off.
Nod. Okay, there we go. Hi, my name is Kate Paris. I'm with United Healthcare. I have the opportunity to work in a division of United that is primarily focused on serving individuals who rely on Medicaid to receive their healthcare. And so we have the opportunity to work across 27 different states in a variety of ways to connect with consumers, to connect with our state partners, and importantly, connect with the providers that serve them. So if we didn't get the best panel to go after for the things that we're talking about, I don't know what it would have been. So thank you so much. Our conversation today is building off of the conversations that we've had so far. It's underscored by a deep partnership and collaboration. So from a United's perspective, what we're trying to do, especially in our Medicaid area, is really focus on helping the consumers we serve live their healthiest lives and do so in a way that makes the health system work better for those that we serve and better for the providers that we partner with. So in the space of partnership, I get the opportunity to work with Amanda. So Amanda, you want to talk a little bit about yourself and your orgs?
Sure. So it's great to see everybody today. My name is Amanda Pierce Kelly. I'm the Executive Director for the Association of Clinicians for the Underserved. We are 27 years old. We were founded by participants and alumni of the National Health Service Corps, which is a really important workforce program, bringing providers to health professional shortage areas, but medically underserved areas. So we have been working with health centers from our inception. Health equity is also, frankly, the health center story. So, and I think many of you in this room are pretty aware of that. But Lucia, I'm just going to tell you, you might have left Esperanza, but you'll never leave the health center family. So you will always say you're with us. But ACU and the work that we do really from its inception has been focused on health equity and JEDI, particularly in the space of workforce, because we know there's no way that you can have an effective workforce if you are not focused on the shared experiences, seeing someone and being able to personally identify with them. All of these things impact the way that the care is received and the outcomes. And so we've been really fortunate to work with Kate and the United team across some really fantastic collaborations, which we're going to get further into today. But I'm thrilled because so much of what we're going to talk about, not surprisingly, brilliant people at CMS who put us all together, but the former panelists really have hit on so much of what we are focused on with the collaboration. So I'll turn it back to Kate.
So we wanted to talk a little bit about kind of the origination of the partnership that we've done around JEDI and kind of how it's seeded some ongoing collaboration and ongoing partnership. So as a managed care organization, especially in the Medicaid space, we rely on the health centers extensively to partner and serve to serve our consumers. Health centers, as you already heard, are deeply connected with the communities that they serve. They understand what's needed, what's happening, what's challenging, and the resources that exist in the community. So a variety of things that we're doing within our organizations are to find ways to partner, to find ways to ask and to listen. So Amanda serves on our National Advisory Board around our FQHCs, where we meet quarterly. They tell us what's working, what's not working, where do we have opportunity to collaborate, where do we have opportunity to advocate together. So coming out of conversations with Amanda and the National Advisory Board and others, we really started saying, yes, we all have been working on health equity for a long time by names that are clearly health equity, sometimes not always, sometimes it's data, sometimes it's really focusing on targeted interventions where we have gaps. And there was a recognition of opportunity. There was an opportunity and a need from the health centers for additional training, additional support, and it needed to come from you. It needed to come from your team and what was needed.
Well, and I think that's also the health center story, right? It's about making sure that there's access to care, but it's also about engaging the community to help inform what that care looks like. And so part of what ACU does is support that. And so we are supporting the clinicians that work in the health centers and in any organization, frankly, on serving underserved populations. And I would say also that, and this has come up, it's clinicians, but it's also healthcare workforce across the board. And that has to do with the social drivers, like the data that we've just seen in the last 45 minutes or half an hour, it tells you, it's not just about the clinical component of what care looks like. It's thinking about things like transportation. It's thinking about things like food insecurity. It's thinking about access, period, whether it is clinical access or just all the resources that you need in order to have those positive outcomes. So when we began working with Kate and with United, I just want to keep us on track with our slides here. When we began working with Kate and with United, it was really through the lens of, okay, what is it that we can do? And the interesting thing with health centers is that because health equity is so fundamental to the work that they do and to the care they're providing to the communities, it's been interesting, at least in our journey at ACU the last few years, to recognize, this may be a 5-decade-long legacy of work, but there's so much more to do, but also in the space of workforce, how do we do a better job of pulling the community into that? What is it that ACU can do to help provide training, tools, and resources to support that on the ground, but also hear from the community what is actually needed? Because I think the other thing with JEDI is that one conversation with one organization is just one conversation. You talk to somebody else in another state, another city, another region, and it's a completely different conversation. And so a lot of the programming and the resources that we've worked on developing take that into account and really customizes the approach with the same foundation, but with the recognition that the needs of that community, the needs from a workforce perspective are going to be different from place to place.
Sure. See anything else you want to talk about on JEDI?
Well, I want to share a little bit more specifically about the workforce issues and challenges that we face, particularly in underserved communities. And so, as I mentioned, we know that the health outcomes are far better when the person that you're receiving care from looks like you or has a shared experience. So ACU's work, we actually have a grant from the Bureau of Primary Healthcare to support clinical workforce recruitment and retention, specifically at health centers. But one of the challenges is that not only do we face a massive workforce challenge nationally, the proportion in terms of people of color, Black, Indigenous, and Latin are terribly underrepresented. And so there is an enormous amount of work to do even to address and facilitate that. And so part of the work that we've done at ACU is to address that. And part of the partnership with United has been around, again, the training specifically to be thoughtful about and take the approach that, okay, we need to do more to improve on this very challenging situation in terms of the healthcare workforce. Some of the specifics that I can just share really quickly here. Through our partnership with United, we've been able to launch several e-courses. Part of what we also try to think through is how do we make this accessible and easy? We know that clinicians and other members of the healthcare workforce do not necessarily have the time to engage in things in the middle of their day, so to speak. And so we've launched a couple of different e-courses. They're currently available. One is Understanding Racism in Healthcare and Tough Conversations, Creating a Space Filled with Grace. So again, some of that comes down to, for example, terminology. The way that people understand even the use of the word health equity, or the way that they understand mission, even inside the organization is dramatically different. And so some of this training is to really help address that so that everyone can be working in the same direction. Again, with that sort of shared mission and goal of outcomes. In July, we're also going to be launching a learning collaborative for healthcare leaders to build a strong foundation for creating a culture of equity and inclusion. That's another part of the component of the partnership and the collaboration that we've had with United. And again, it's to sort of integrate JEDI into identifying the needs and then leveraging funding opportunities to support that and developing action plans that are really customized to the organizations in their communities.
Where can people go to get the information, and can they engage in it?
They can. So you can, okay, sorry. I'm like, okay, where are we with the slides? So you can access that on the ACU website. It's clinicians.org. I have to call out our senior director for JEDI, Sabrina Edgington. She's not able to be here today, but she is just an absolute rock star. She is our leader in this space. She has just done a phenomenal job of building the programming out. She's very responsive and available, but if you go to clinicians.org, you can access all of these resources, and there's a lot of work to come. I think the other thing that I would call out is that and we heard it here today, you know, there are so many different social drivers and there are a lot of resources needed. And unfortunately, underserved communities are not the first place people look when they want to put resources towards something. But I'm really grateful that we do have collaborators like United and others who are committed to really looking at and doing the hard work of how do we address these things to see those better outcomes.
I know it was not on our summary of what we were going to present today, but I wanted to just, given the conversation that we've had about health-related social needs and social drivers of health, let's talk a little bit about ACH and our partnership in this space. So Amanda has this amazing opportunity to wear two hats. She not only wears the clinician hat, but she also works with a variety of health centers, really driving some innovative best practices and some kind of continuing to push the envelope. And can you talk a little bit about the entrepreneurship program and the work that you're doing there?
Yeah, so Kate is right. I am very fortunate. So I wear the hat at ACU. I also am the CEO of Advocates for Community Health, which is also a national membership organization geared at health centers. There are a lot of organizations doing amazing work in this space, Vacheria also. So we're fortunate for that. But we are lucky at ACH to be also collaborating with United Healthcare and we just launched an entrepreneurship grant program. And basically it's to harness the innovation, the vision, and the approaches and the sort of pilot opportunity at member health centers with ACH because they know best. And so I'm thinking of Esperanza where it's like you saw what was needed in your community and you needed resources to help get it off the ground to create that opportunity for intervention to then show the outcomes. And so the entrepreneurship challenge and the grant program is that. It is basically putting resources in the hands of health centers to be able to say, look, if you have an idea that's outside the box that you think is really going to produce positive outcomes that can be innovative, let us help you do it. And United has been the partner to do so. So we just launched this just in case anyone's interested, is an ACH membership opportunity, but the applications are due July 14th. So it'll be a 2-year span, but we're really thrilled because it puts the power in the hands of the organizations to determine what is actually needed to address health equity and true transformation. And I guess the last thing I'll say is that I am so grateful I've been working with health centers since 2005 and fell in love with them. I remember someone saying, oh, once you get to know them, you'll fall in love. Well, it's absolutely true. I can't imagine doing anything else now. But the one thing that drives me crazy is that as amazing as health centers are, and others doing incredible work in underserved populations, we've been talking about health equity. We've been talking about health disparities. We've been talking about this work and doing good work for decades, long predating me. But you still see the data. You still see the health disparities. Unfortunately, the pandemic blew the doors off of how badly we're doing with that. And so the space that I find myself in most recently in the last several years is how do we really achieve transformation? And what it looks like is a lot of what's been talked about today, but I think it is also partnerships like this where instead of trying to dictate what they think it should be, it's allowing the people on the ground, it's bringing people in the community into the conversation to address what we actually need to do to go from checking boxes and addressing health disparities, but really getting to transformation and really achieving health equity. Instead of sort of what I would call slapping a Band-Aid, which, hey, I'll take the Band-Aid every day, but what I really want to see is transformation. In an ideal world, and my members might yell at me for this, I'd love to see health centers put out of business. You don't need them anymore because these communities are truly thriving and transformed. So we're working on it, and I have great optimism and hope hearing honestly from the other panelists today, because I think we're moving in the right direction and just grateful for the opportunity today. And all of you in the room, because I'm sure you're doing great work too.
Thank you so much. Do we have any questions for the panelists? I saw one right here.
So those are all really good questions, and none of them have short answers, but I'll do my best in the time we've got. And Kate should chime in too, because I think there's some elements that she can chime in. But so the trick with health centers, or not trick, but the reality with health centers is that they see all patients, everyone who walks through their doors, regardless of insurance status, ability to pay, all of it. So for those that are in Medicare, they're treated frankly the same way. The health center is basically engaging with whatever coverage that they have. And so that's the simple way of sort of explaining that. In terms of someone who is privately insured, same thing. The health center is engaging with those private insurers. Someone that is uninsured, they still come in, they still have to be treated, and they will still receive all of the services, including an extended and or expanded set of services when you compare us to private providers. That's part of our model. For someone who is uninsured, basically there's a sliding fee, and that's where their grant dollars are intended to be used, is basically to say, okay, we're going to guarantee you can have access to care, and if you're not in a position to pay, then we'll work with you. That's the sliding fee piece of it. Do you want to, anything
Sure.
else?
I can take a couple, lots to unpack with the question, but a few things. Number one, it's continuing to strengthen the capacity and the partnership with community health centers, either by working in partnership with the National Association of Community Health Centers, working with rural health centers, working with ACH, variety of organizations where we're continuing to work to build that capacity. Because as Amanda noted, right, it's not just the Medicaid population that they're serving. We need capacity in our communities broadly. Additionally, within the United space, we have done a variety and are continuing to advance work on communities of health. So we recognize that many of the communities that we serve, it's not only the Medicaid population that we serve, but we're also managing some of the employer-sponsored coverage in those markets. We maybe have employees of our own in those markets. We've got retirement individuals who are on our Medicare Advantage plans. And in those areas, again, we're looking to find strong community partners, both ones that are in the weeds of providing healthcare delivery and healthcare services, but also the community-based organizations that were mentioned earlier, and really trying to see through the data, in specific the healthcare utilization data, but also on the health risk screenings or screenings for social determinants of health. What is the need? And looking through the data to say, hey, this is what we're seeing. Tell us the story behind it. What do we not know by what we're seeing? And by convening a group of individuals who are from the community, who sit at different parts of the table, who have different perspectives, we're able to say, okay, so what do we need to collectively do? So in some areas, there's opportunity for us to bring in additional data resources, additional tech, additional support. In other areas, it's some initial seed funding. Most of the time, it's just the right partners and the right conversation, and bringing forward the snowball effect of partners around the table starting to have a conversation in a new way with new information, new data in front of them, and then continuing to pick away at particular intervention, particular opportunity, bringing in additional capacity and resources. So we do that in many ways from the Medicaid lens because we need to in our Medicaid space. The opportunity that's been so exciting for those of us who've been working in this space for a while is an increasing awareness and increasing partnership across our lines of business to recognize it's the same zip codes, it's shared zip codes, shared data, shared opportunity.
The one thing I would say to Lucia, and I know there was another component to the question that I don't want to skip over, but you mentioned the importance of having people from the community at the table and having these conversations, which I could not agree with more. And I would just say that from a partnership perspective, I have been really impressed and grateful because every conversation that I am fortunate to be a part of with United, they always have a patient advocate there. They always have multiple people from the community. They also bring in health center leaders who are, leading in the community they're serving, but there's an intentional inclusion in terms of all layers, and that's somewhat rare. I think it's a model that's expanding, but I think that's when we see the best outcomes too.
So we are right at time. I want to give a round of applause for all of our panelists today. And I guess I'll just say one of the biggest takeaways I took from this is how important it is to have community-based partners integrated in this work, and that health equity is not just about access to health care, but also the barriers that prevent people from thinking about it. You can't think about your doctor's appointment if you don't know where you're going to eat, sleep, or how you're going to eat that night. So really glad we're all here, and thank y'all for joining us.